Dr. Moradeyo Adedeji Yusuf.
That's for the warm introduction. Good afternoon, everybody. We'll be taking the discussion on the Scourge of Lassa Fever. And I'll be speaking through the outline listed. After the discussion, it's believed that we'll have an high index of suspicion of Lassa fever virus, have the understanding of the disease burden and risk, and understand the importance of the universal standard precaution. By way of introduction, Lassa fever is an acute viral illness. It's one of the viral hemorrhagic fevers and is largely a zoonotic disease, meaning transmission from animal to human. It's also a preventable disease and is of public health importance. So it's one of the notifiable disease amongst us. And it's also important because it has a period of epidemic and endemicity within the sub-Saharan region, and Nigeria is inclusive. So it's become a very important disease that needs to be actually curtailed. Lassa fever was first discovered in Nigeria in the Lassa town in Borno State in 1969. And this was actually first isolated by a physician abroad. Though Lassa fever has been there since 1950, but not isolated until this time when the missionary in Borno State were actually infected with the virus. Like I said, it's majorly a zoonotic disease, and that's the primary mode of transmission from the multi-mammate rats to humans. But it has been identified that there's a secondary form of transmission, which is transmission from humans to humans. Lassa fever has an incubation period of 3 to 21 days. And it's endemic in Nigeria. Endemicity means it's present all year round. Even though we have peaks of high infection, that is the epidemic. And the epidemic of Lassa fever is highest between the month of November and April. That is the late rainy season to the dry season. We'll get to understand that in a short bit. But why is Lassa fever of concern? It's of concern because we know, yes, the primary transmission is from the multi-mammate rats to humans, but concern is the secondary transmission really among healthcare workers, because we interact with a couple of patients within the facility, goes to the community and interact with them. So this cadre of staff, it's important that Lassa fever be curtailed or prevented among them and managed appropriately. The global incidence of Lassa fever is between 100 to 300,000 annually. And in West African sub-region, more than 100,000 cases have been recorded with a mortality of 5 to 10% among hospitalized patients. And the case fatality actually ranges from 1% to 15%. Now, Lassa fever, like I said, is endemic in sub-Saharan Africa. And some of the countries that have high burden of Lassa fever include the Benin, the Ghana, Togo, Mali, Sierra Leone, and of course, Nigeria. Lassa fever has no age predilection, has no gender predilection either. And the Lassa specific antibody, which we refer to as the herd immunity, ranges from 1.8 to 55%, depending on the region and location of the infection. Like I said, the reservoir host is actually the multi-mammate rat. Yeah, you can see from the picture, it's usually a rat with about 12 mammary glands with pointed nose. And it has been identified that about 30% of the rats are actually reservoir for Lassa fever virus. The mode of transmission is usually by direct contact, and direct contact either with secretions from either infected individuals or ingestion of food that have been exposed to the excrete of these rodents. Because the multimammates or the Mastomys natalensis has been widely documented as the reservoir, even though other mammals could actually be reservoir. But this has been documented in various studies as the main reservoir host for the Lassa fever. Now, you can also contact Lassa fever through inhalation, either via procedure while attending to patients in the ward, either from suctioning and all that. If adequate protective equipment are not used, but it should be largely known that it's from direct contact, either from the waste of patients infected with Lassa or ingestion of droppings from contaminated with excrete from the rats. Now, this pictogram depicts areas within the country with large burden of Lassa fever. Of note is Ondo State. Ondo has the largest or the highest burden of Lassa fever in the country, followed by Edo State, followed by Ebonyi, Benue, and Taraba. You can see Bauchi also. So from the red dots on the screen, you can see some of the regions. Now, this is not to say other states have not reported the case of Lassa, but you can see some of the color, the gray color or slightly brown. Those are regions over time, especially this year, have not reported any positive case. But you can see that most of the states, about 26 states within the country, have reported at least a case of Lassa fever. Now, this is just to take us a bit back about the representation of Lassa fever in the country. Using the 13th week, this is a situation report for the country. And of importance is the confirmed case. In 2023, there are about 846 cases at this time. But in 2024, we have 806. But you could see the number of suspected cases, which means there's an heightened awareness of the disease. But the case fatality is higher this year, 18.6 compared to 17.5. And it's also important to state here that among this number, we have had, at least last year, there are about 42 healthcare worker infection. And this year, we have already recorded 31. And that is significant for us. Now, when we compare the statistics from week 13 and that of week 15, and the week 15 will stop at 14th of April, you can understand that the statistics that we're seeing, despite the fact that the number of confirmed cases in 2023 is slightly higher than what we have here, but we notice that the mortality rate has increased. Now, even though it is not documented, but what we found out was that late presentation this year increased the mortality, late presentation decreased result availability to commence treatment, contributed to higher mortality as against the previous years. Now, looking at Taraba State, where we are, the number of suspected cases as of 2023 was 229, with a positive case of 96, compared with the first quarter of 2024, where we already have 204 and a positive case of 89. But when we look at the case fatality for them, we could see that as of the first quarter, we're already having 34.8. And for the whole year of 2023, we had 35.4. Now, this is also too good to bear why the month of epidemic is higher. We start from November to April. The first recorded case in Taraba here, Jalingo, was in October. We had a case. While in November, we had a multiple cases of more than 40, as it were. But as the month progresses, the cases also decline. Now, one of the practices, like I said, is the habit of individuals because this is the period where people dry their grains, so they are exposed. And hence, there may be a possibility that the rodents may have passed maybe their excrete on some of these grains that were poorly prepared and ingested. Or there are interactions with individuals that already have the virus unknowingly to other persons, either because they're exposed to large gatherings or because they are in denial of the fact that their relations may be positive. So the interaction increases. And because of the late presentation, like I said, the mortality has increased. Now, in Taraba State, we have 16 local governments from the bar chart that we could see, and 16 of about 12 of them were already having positive cases, with the largest. You can see the blue and the orange. The largest is Bali local government, followed by Jalingo, the capital, and we have Karim Lamido, Adokola. But it's important to know that of the 16, 12 local governments already had positive cases, and that is alarming in itself. One in our treatment center here in FMC Jalingo, putting in perspective, in 2022, now these are not documented, but at least it was gotten from records. We managed 39 patients, discharged 22 with 11 mortality. In 2023, we had 76 admissions with 38 mortality, while in the first quarter, we had 44 admissions with 10 mortality. And this puts the mortality is 22. Compare 22 to 44 in 2024 alone, that means 50% mortality was recorded as against the 21.4% and the 28.2% respectively, to tell us that the burden of the disease and the loss from the disease has increased exponentially from the previous year to now. Taking us further, we want to talk about the presentation. How do people identify the Lassa fever disease? Interestingly, about 80% of patients are actually asymptomatic or may just present with mild disease. For asymptomatic individuals, they don't have any symptoms, so they interact with every other person. But for individuals that may present with mild disease, they present with unconstitutional symptoms like fever, headache, generalized body weakness, sore throats, diarrhea, vomiting, abdominal pain, or chest pain. While for the other 10 to 20% that may present with severe disease, the severe disease simply means they have complications of the infection in itself. That includes the acute kidney injury, bleeding from sides, hearing loss, especially in children. Some of them may present with sepsis or shock, especially after blood loss or fluid loss, respiratory distress, having seizures, restlessness. Some of them present unconscious. In children, we may see neck swelling. And for pregnant women, the increased rate of pregnancy loss has been recorded as a matter of fact, I think about 80 to 90% of pregnant women with Lassa fever virus actually have pregnancy loss. Now, how do we identify a case to say, okay, this is Lassa? What do you mean a case? It just means a set of criteria that must be fulfilled for an individual to be represented with a particular disease. There are a lot of criteria used: laboratory, clinical, or geographical location. It's important to state categorically, when we say disease is endemic, regardless of the local government in that state, it means that at every point in time, individuals in that state are at risk of actually contracting the virus. So it's comfortable to say probably people in Jalingo, since it's an endemic area, we actually suspect. Yeah. So how do we categorize our patients based on this set of criteria? There are 4 ways to categorize patients. Either they are alert cases, suspected cases, probable case, or confirmed case. An individual is said to be an alert case if the person had unexplained fever after ruling out other causes of fever, with or without bleeding, or individual died with an unexplained severe illness with fever and bleeding. That is an alert case. A suspected case is a person with a fever of greater than 38% within the incubation period of 3 to 21 days of the virus with symptoms suggestive of mild disease, the individual is termed a suspected case. While for a neonate, if the mother is positive for Lassa fever regardless of symptoms, the newborn is a suspected case. Other criteria we could use as a suspected case is if an individual is not responding to a standard anti-malaria or antibiotics within 48 to 72 hours, which means the temperature is not decreasing upon treatment, we should suspect Lassa fever. Or a history of contact with a probable or confirmed Lassa fever case within 21 days of onset of fever, the individual is also termed a suspected case. Or there's a history of travel to a high burden state. Like I likely say, in Nigeria, 6 states have been identified as high burden: Ondo, Edo, Bauchi, Taraba, Ebonyi. So travel to those regions with fever, the individual is also termed a suspected case. Or contact with body fluid or tissue of a dead person with febrile illness with symptoms suggestive of that of Lassa, or any bleeding from any puncture site or craniofacial orifice, or uncontrolled bleeding upon surgery or irregular messes, the individual is also considered a suspected case. Now, when do we say an individual is a probable case? An individual is said to be a probable case if the individual has symptoms suggestive of the severe symptoms that we have earlier outlined, like seizure, restlessness, acute kidney injury, abnormal bleeding, hearing loss, with temperature of greater than 38 degrees. With those symptoms or complications, the individual is termed a probable case. Or individuals with those mild symptoms with some laboratory values, such as urinalysis having proteinuria or hematuria, or an elevated creatinine levels, or an elevated liver enzymes, or a reduced platelet, or the active phase reactant protein like the ESR or C-reactive protein. Either of these laboratory values, in any suspected case, the individual becomes a probable case. Now, the absence of any of these symptoms, like we rightly said, does not rule out Lassa fever, because we said 80% are actually asymptomatic. So for a patient that have been managed for other conditions and within the endemic zones and the individual is not responding, please we will consider Lassa fever as a differential in such individual. Why for any of these cases that have a positive polymerase chain reaction, the individual is termed a confirmed case. Why the treatment is for probable and confirmed case. For suspected cases, the individual are actually triaged and isolated until the lab result is out. Now, case identification. Having known some of the criteria for those patients, if the patient presented to us in our service points, they must be triaged using the SIN approach. The screening, the isolate, and to notify. How do we screen? From history taking, asking for those above symptoms, drug history, examination of the individuals, and like I said, auxiliary investigations, like we said, urinalysis can be done on the spot, especially for individuals we think is a suspected case. After screening such individuals to either a suspect or a probable case, they are isolated into an holding area, because each of the facilities is expected to have an holding area where infectious diseases are kept before actually taken to the treatment area for proper treatment. After isolating those individuals, the appropriate authority needs to be notified. Now, most local governments, I won't say all, but at least most local governments in the states has a disease surveillance and notification officer in all local governments. And for each facility, it's expected that they have a focal person, that for any of those suspected cases, the focal person needs to be notified and the GCNOs need to be notified so that the state epidemiologists can also be notified. Like I said, it's a notifiable disease. And for any suspected case or probable case, the epidemiology team in the state needs to be notified. Now, I've mentioned some of this. I won't go through this again. It's just a screening tool that we use in the facility to actually look at the mild and the severe cases. Now, differentials of Lassa fever. Like I said, some of the mild cases we have, like I said, they are non-constitutional, which means more other conditions present similarly. If an individual presents with fever, body weakness, joint ache, the first thing anybody wants to think of in our setting is malaria, and typhoid fever. But if after treatment, 2-3 days and the fever is not remitting, please, let's consider Lassa fever. The same thing goes for diarrhea disease. The patient may present with diarrhea and vomiting. The natural thing to think first is acute diarrhea disease. With fever, you may want to think of an infective diarrhea, but with treatment and the fever is not remitting, symptoms not abating, please consider Lassa. Now, peradventure, even with the PCR, the individual is negative and still has symptoms. Lassa fever is just one of the viral hemorrhagic fevers. We could think of other viral hemorrhagic fevers. In our malignancy, chronic diseases can present similarly. And bleeding diastasis, DIC, sepsis can present with bleeding. In as much as the individual can be termed a suspected or a probable case, we should also consider that other conditions, other comorbidities can coexist, despite the fact that we think of Lassa fever. And that is why you will understand from the data earlier presented, we had a lot of suspected cases, about 5,000 plus within the country, and about just 802 were positive after a PCR test. That does not mean that they may not have other viral hemorrhagic fever, but the PCR, that's the polymerase chain reaction for Lassa fever, was negative. So we need to consider other possibilities in such individuals. The diagnosis of Lassa fever is made using the real-time polymerase chain reaction, using the blood samples usually. Any of the body secretion could be used, but it is preferred that the blood of the individual is taken. Now, other auxiliary tests that must be done is based on the individual at present, depending on how they present. But like I said, in centers that don't have the PCR, other auxiliary investigations that could be done to either case the individual as either a probable case, include the urinalysis, the liver function test, the full blood count, which is available in most centers, place the individual as a probable case, and that individual, based on the national guideline, can be treated while we await the polymerase chain reaction for Lassa fever. In managing individuals with Lassa fever, though the good standard of treatment is with the IV ribavirin, but it is important to note here that for every patient that presents, supportive care is as important as resuscitation before the adequate care, because most of these individuals present with other comorbidities. So it's important that, yes, we resuscitate these individuals, avail them and manage other comorbidities. Important of them is IV fluid. Adequate hydration of the patient is key, because ribavirin has been notorious for also worsening an acute kidney injury if present. So it's important that the individual must be adequately hydrated. Now, 2 regimens have been adopted with the national guideline, the Marconics and the IRUA regimen. We're all familiar with IRUA in Edo State. They have their own regimen, while the Marconi is the WHO agreed standard. So either of them works. For the non-pregnant adults and children, it's the same thing. The ribavirin is calculated per kg. The loading dose, 33 milligrams per kg, not exceeding 3 grams in an individual as the loading dose, then 16 milligrams per kg for 2 to 4 days, then 8 milligrams per kg for 5 to 10 days. The difference with IRUA and the Marconi is that IRUA has a higher loading dose, and the milligram per kg for the other days are daily, 25 and 12.5. However, for pregnant women, the modified Marconi is used, whereby the loading dose is similar to that of the IRUA's regimen, while the day 2 to day 10 is similar to that of Marconi's. And like I said, the other comorbidities need to be managed appropriately. Lassa fever is a preventable disease, so emphasis should be made on prevention. What if it's present management you treat? First of it is education. which is one of the things we are doing today to educate ourselves and the populace, educate them on the symptoms, early presentation to the facility, counsel them on the need to be managed in the treatment facility in isolation centers. So they need to know, understand the source of the infection, usually the rats. So we counsel against ingestion of poorly prepared rats or hunting of rats if possible. Then proper preservation of our foods or grains. Importantly is the infection prevention control and universal standard precaution, which we will mention shortly. And that also falls under the contact precaution, where we'll be using our personal protective equipment. And vector control, even though this in itself is the elimination of the rodents, some countries adopt the use of cats to chase the rodent, but some of the practice that we do is bush burning, and this eventually chase those rodents into our communities, further worsening the infection. And safe burial, our burial practices for some of the way the corpses are treated is also a means of infecting other people, either the person taking care of people handling the corpse. Naturally, there are safe burial teams within the state that help with that. The patient is bagged and sprayed with 0.5% of chloride to prevent this infection and all of this. So running through this is just to enlighten us about the chain of infection. These are modes to how the infection can be broken. Usually the reservoir of an infection is usually the vector. In this case, is the multimammate rat, and the infectious agent is the Lassa fever. So all individuals are actually susceptible, except for few that had herd immunity, and that does not mean they can't come down with the infection, but however, the infection may be mild. Part of entry of the infection, like I said, is via contact. So through the hands, through the orifices or a cut skin, where the organism have direct access into the host. Like I said, the mode of transmission is through contact, and the exit of infection usually is almost through the route of entry, through the hands, the nose, without appropriate PPE. And the idea of infection prevention is to curtail or break this chain of transmission among individuals. What are standard precautions? They are just routine activity that must be practiced on all patients. And this minimizes the risk of infection among individuals, healthcare workers, and all of that. High top is the hand and respiratory hygiene, adequate hand washing, use of running water or alcohol-based rub, or respiratory hygiene, use of the nose mask. Cleaning and disinfecting or sterilizing reusable equipment. That's where the health attendants come into play. You give them disinfectant to clean the equipment, sterilize, autoclave, and all of this prevent that. An appropriate handling of the waste generated. If the waste, like I said, one of the contacts is exposure to excrete of these positive patients, we'll get to see some of the grading of the waste. So adequate and prompt waste segregation is key in preventing transmission of infection. All staffs are an individual is a collective responsibility to prevent the spread of all organisms. If some of the highlighted points are actually taken to bear, rate of infection, even among healthcare workers, will be minimal. Hand hygiene, I will just describe some of the moments, and there will be a picture to describe how this can be done. Some of the 5 moments that WHO have put to bear is 1, before touching a patient, hand hygiene must be performed. The second moment is before any aseptic procedure, that any procedure at all, either setting of line, inserting of urethral catheter, inserting of NG tube, hand hygiene must be performed. Or after exposure to any body fluid, either blood, urine, stool, hand hygiene must be performed. Or touching the environment, either the bed, the given set, the patient environment, the tables, the bed etiquette, hand hygiene must be performed after such, or after examining or touching a patient. Hand hygiene needs to be performed to minimize spread of infection either to the health worker or to the next patient the health worker may be exposed to. Some of the other indications may be before leaving work, after resuming work, obviously before and after eating is important, preparing meals, and after using the restroom. Now, this picture depicts some of the aspects of the hands that have been identified to have poor contact while performing an hand hygiene. You can see that the green part is the areas that are most mixed, the dorsum of the fifth finger and that of the first in the plantar surface. Then the most often mixed are the interdigit space at the back of the thumb, at the areas. Now, this pictogram depicts the sequence to which hand hygiene is expected to be performed for adequate protection. And every hand washing using water should last for 40 to 60 seconds. First, the hand is wet. Then liquid soap is preferred to the bar soap. Then a circumvent movement within the palm. And what this do is to clean the nail and the tip of the nails, while the third step, rubbing through those dorsum of the hands to help clean the interdigital spaces. The same thing with 4, both dorsal and the plantar. While the 5, help clean the intertarsal space of the hands. While the 6, the thumb, and that is repeated on the other hand, then the hand is rinsed, preferably in running water. Most centers may not have this. Veronica bucket is important to be available. It's not advisable to be fetching from a bowl, from a bucket and rinsing the hand, because that's another way of contamination. After that is done, a tissue paper is ideally meant to be available, which is used to soak or damp the water, and the tissue is actually used to close the tap while the hand is allowed to air dry. Some has a hand dryer, and after damping, the hand itself is allowed to hand dry. This process should take about 40 to 60 seconds for adequate hand hygiene. Now, this is similar for the alcohol hand-based rub. The difference is that this lasts for 20 to 30 minutes and you don't need to wet your hand. It's actually not advisable to use an alcohol-based rub and also wash your hand. You either pick either of them. The indication for hand washing with water really is when the hand is visibly soiled, either with the excrete or not. But for our routine patient, and alcohol-based rub is sufficient. And the method is similar, with about 2 to 5 mils of the alcohol-based rub. Follow the same pattern as of hand hygiene. Afterwards, the hand is allowed to air dry. Now, that is for that. Now, for the use of the personal protective equipment, the use of this is as a physical barrier to prevent infection, really. I will just list some of them and explain how so that we don't waste so much of the time. The gloves, the mask, the goggle, the face shield, and the apron and the boots. Those are the common, and what is omitted here is the cap. Especially for the surgeon, you need to have a cap. Now, the aim of all of this is to actually to prevent the spread of infection among healthcare workers, either among themselves or healthcare worker to the patient or patient to healthcare worker. Now, this becomes very important that in attending to patient, there's what we call appropriate PPE, which means depending on your interaction with the patient, determines the level of personal protective equipment you need to put on. For a patient going to the treatment center, we expect you to have a full regalia of a gown. But for patients in the ward that you just want to examine, it's safest. Put on your gloves and put your nose mask. It's important. That is sufficient to actually prevent an infection. For individuals or surgeons, it's important that your goggles, your aprons, your mask, and your gloves, sterile gloves in this case, is advisable because there may be spillage in theater and all of this. So it's important that any of these PPE are used appropriately. It's not that because you want to see a patient, then you must put a full regalia. There are some individuals, you don't even need to wear your gown. Your apron is sufficient to examine a patient. But please, Going into the treatment center, you must put on the full complement of your PPEs. But these are just pictures to depict how to wear and how to unglove. Okay. Well, this is important. After putting on your gloves, to unglove to minimize infection. The first glove, you pinch from the surface and pull out, roll it out. That is before. Why the second glove? Why removing it? Because it assumes that the inner aspect of your glove is sterile enough. Then you put your hand into the second glove and roll it out and roll it upon each other like a ball, then put in the waste bin. But please, it's important to state here categorically, hand hygiene needs to be performed before wearing a glove, regardless of the patient you're attending to. That is the way to actually prevent infection. Nose mask, I've explained this. This prevents, is a breathable mask that helps to limit inhalation of some of the droplets and all of this. And there are various types. The normal surgical masks that we use are actually meant to be disposable, a one-time use. And if they are soiled for obvious reasons, either via sneezing, need to be changed. So I don't need to. I've explained the need for the goggle and the shield. For emphasis, please, for any procedure that may require spillage, splashing, please, you need to use your goggles or the face shield to prevent or limit infection. For the gowns, I've explained that. Now, it's important to state here, for individuals that may be in treatment center or have a probable case or a confirmed case that may need to be examined, the donning of a gown and doffing are please done in a restricted area. Usually, in donning a gown, you need an assistant. Because before you don, hand hygiene needs to be performed. One, to minimize spread, because coming from outside, the hands might be infected and you may have touched the environment. So it's important that you do an hand hygiene. The assistant must also do an hand hygiene. When picking the gown, depending on the type, there are some that need to be tied from behind, there are some that has a zip. The assistant helps wear the gown. After which the gloves is put on, the boot is put on before either the goggles and the cap. Then while doffing, the first thing to doff is the gown, and it is done appropriately. The assistant help untie, while the individual pinch from the front, pull forward, roll forward, and remove one hand after the other. Now, the ideal thing while doffing is while removing the gown, the gloves are actually also removed alongside, because the inner surface of your gown is assumed to be sterile. So while removing the gown, you can see from the last picture, the first hand is out, while the second hand helps guide removal of the second gown and the gloves, and it is rolled gently and put in the appropriate waste bin, which we will see in a short while. These are various boots that can be used. Now, for waste segregation, the individual that generates the waste, ideally, should actually dispose of the waste in the appropriate containers. There are containers meant for waste segregation. Now, I will just run through so that because of time. Now, for the black waste bin, each of the waste bin ideally should have a lining. And the lining are color coded just as the bins. And it depicts the type of waste that should be segregated via those. In some centers, they may not have enough linings, but at least the color coding helps to determine the type of waste. And that also helps the handling of such waste. For dark or black waste bin, they are meant for non-infectious waste, like the papers, tissues, nylons, and all of this. And these usually are the waste of the patients. Usually is lined with a black lining to depict. In some centers, what is done is there is a basket under the bed of such patients. Those baskets are ideally meant for only the patients, not for the healthcare worker to use the glove and ungloved and drop it in that basket. The waste bins are actually meant for the patients, and they are usually non-infectious. For the yellow bins are for relatively infectious but not highly infectious waste. And these are done either with your gloves, the giving set, blood giving set. For non-infectious patients, they are put actually in the yellow bin. In some centers, they both have the white and yellow, but most of the time, the yellow bin is readily available. While the red bins are for highly infectious waste. And these are usually found in our wards for patients that may have highly infectious disease or in the treatment center. And the waste are segregated. And like I said, all waste bins should be lined appropriately. Now, this cadre of bins are meant to be in all our various wards and service points so that the waste can be adequately segregated. For the sharp box for every other patient are usually in a paper box like we have in most cartoons, like you can see in the first image. Ideally, some centers may have these normal waste bins that are also color-coded that are used specifically for sharps. But for highly infectious sharps, if a carton is used, is labeled, or a red sharp box is used to segregate waste. We don't segregate our sharps with other wastes. They are segregated in different containers, but the color coding tells how infectious those wastes are, so that the people disposing take precaution in disposing some of the waste. And you can see as itemized here also. So by way of conclusion, Lassa fever is an infectious disease largely preventable, like I've said, endemic in sub-Saharan Africa, which Nigeria also belongs. High index of suspicion is needed considering the symptoms that I've highly mentioned. Infection prevention and control measures should be instituted at all times, and this is the bedrock in preventing all forms of infection as the case may be. Local authorities need to be informed of any suspected case that are identified, and because it's a notifiable disease, the GCNOs need to be notified of such cases. And contact identification is very critical in controlling the increase of transmission of those diseases. This is what we refer to as contact tracing. And that is why it's important for the EPID unit of the state or the local government to be aware, so that contacts of the suspected or positive case are also contacted and monitored to prevent spread of infection within the community. Thank you for your patience. These are my references.